Welcome to this clinical reasoning challenge titled The Unyielding Shell. As you can see on the opening screen, we are exploring the case of a 50-year-old man who presents with a complex mix of subacute constitutional symptoms and acute chest pain. This session is designed as a staged journey where we will navigate the diagnostic tension and the evolution of pericardial disease. Notice the diverse perspectives listed here, ranging from a hospitalist and a resident to an expert clinical reasoning model. We will examine how anchoring bias can cloud our judgment and how a patient's clinical picture can shift dramatically over time. This case is not just about a diagnosis, but about the process of thinking through uncertainty in a high stakes environment. Let us begin by looking at what we hope to achieve during this discussion. Looking at the learning objectives on the screen, our discussion will focus on two primary areas: clinical reasoning and management priorities. In the realm of reasoning, we aim to recognize diagnostic pivots in subacute syndromes and understand the limitations of testing in patients from endemic regions. We must also learn to differentiate between an idiopathic label and a persistent search for a specific cause. On the management side, as seen in the right-hand box, we will prioritize hemodynamic stabilization and identify the transition from effusive to constrictive physiology using non-invasive imaging. Balancing empiric therapy against tissue-guided management is a critical skill we will refine today. To reach these goals, we will follow a specific structure for our analysis. This slide outlines the session format, showing how the discussion will unfold across 5 distinct stages. As you can see in the list on the left, we will move from the initial presentation and investigations to the eventual clinical deterioration and final confirmation. On the right, notice the 4 perspectives that will guide us. The doctor reveals objective data, while the resident offers a broad first-pass interpretation. The attending then critiques the safety and calibration of that logic, and finally, the expert synthesizes the findings to identify the most likely unifying syndrome. This multi-layered approach helps us simulate the real-world complexity of medical decision-making. With this framework in mind, let us examine the patient's initial clinical data. The initial presentation for our 50-year-old male from North India is quite striking. As you can see in the history box, he has experienced 5 days of sharp pleuritic pain and a heart rate reaching 160 beats per minute. More concerning is the 4-week prodrome involving fevers, chills, and a significant 4.5 kilogram weight loss. Looking at the emergency department findings, his heart rate remains very high, between 142 and 160 beats per minute in sinus rhythm. Laboratory results show a low sodium of 129 millimoles per liter and a high platelet count of 548,000. The chest X-ray reveals cardiomegaly and a blunted costophrenic angle. Before we move to the next stage, let us pause to consider the implications of these findings. We have reached our first audience. Pause to interpret the constitutional burden of this case. Looking at the questions on the screen, we must ask how the patient's epidemiology reframes that persistent tachycardia. We also need to consider the significance of a sodium level of 129 and a platelet count of 548,000 in this specific context. Does a normal high sensitivity troponin level truly rule out acute pericardial distress, or could something more chronic be occurring? Finally, think about what the single most urgent investigation would be for this patient right now. These questions are designed to challenge your initial impressions and prevent premature closure. Now that we have considered these questions, let us see how our different clinical perspectives interpret the situation. As we examine the reasoning at stage 1, notice the different priorities of our 3 clinicians. The resident suspects tuberculosis pericarditis at a 60% probability, using the weight loss as a critical pivot and requesting an urgent echocardiogram. The attending, however, critiques this as potential tuberculosis first anchoring. They suggest considering malignancy or even an idiopathic cause with a superinfection, demanding immediate risk stratification for tamponade. Interestingly, the expert perspective on the right unifies the case as a subacute pericardial disease. The expert identifies the key pivot as the combination of a constitutional syndrome and the patient's origin, which necessitates a specific cause. While the expert identifies the need for a specific cause, let us look at the investigations in stage 2 show a shift from simple fluid to something more complex. As you can see in the imaging results, the computed tomography of the chest shows a moderate effusion and diffuse thickening along with a 5 mm left upper lobe nodule. The echocardiogram reveals a large heterogeneous pericardial echo density and a small posterior effusion with a reduced left ventricular ejection fraction of 35-40%. On the right, the initial cultures are mixed with a negative induced sputum smear for mycobacteria, while the full culture remains pending. These findings suggest that the pericardium is no longer just a sack of fluid, but is becoming a solid, organized structure. These imaging results add a new layer of complexity that requires closer examination. This second audience pause focuses on the concept of the dry pericardium. Looking at the questions on the screen, we must determine what the term heterogeneous ecodensity actually implies for the patient. Is this an active infiltrative process, or is it simply organized fibrin from a previous inflammatory event? We also need to consider how the new finding of the ventricular dysfunction with an ejection fraction of 35 to 40% changes our diagnostic frame. Furthermore, we must ask if a negative sputum smear should truly lower our suspicion for tuberculosis in a patient with this history. These questions highlight the difficulty of interpreting imaging in the absence of definitive pathology. Let us see how these objective findings shift the diagnostic reasoning of our clinical team. The reasoning at stage 2 reflects the shifting morphology of the disease. The resident now pivots toward a solid process, such as organized fibrin or a mass, but still keeps tuberculosis as the lead suspicion at 45%. As you can see in the middle box, the attending argues that the likelihood of tuberculosis is actually over 60%, given the mass-like density and demands an immediate heart failure strategy. The expert synthesizes these findings as a caseating or organized inflammatory pericardial mass. The expert notes that the critical pivot is the transformation from a simple effusion into this thickened mass-like process. As the team synthesizes the possibility of an inflammatory mass, we move to the search for tissue confirmation. In stage 3, the team pursues a biopsy and clinical labeling. As you can see in the further workup box, the biopsy shows organizing fibrinous pericarditis and atypical mesothelial proliferation. A cardiac magnetic resonance imaging scan confirms an 8 mm thickened and enhancing pericardium with a loculated effusion. Looking at the consensus diagnosis on the right, all serology for human immunodeficiency virus and autoimmune markers came back negative. The adenosine deaminase was 20 and the C-reactive protein was 13. Based on these results, the patient was labeled with acute idiopathic pericarditis and started on naproxen and colchicine. While his symptoms initially improved and he was discharged, we must ask if this truly confirms the underlying cause. During this audience pause, we reflect on the response to treatment versus the actual diagnosis. The central question is whether symptomatic improvement on non-steroidal anti-inflammatory drugs actually proves the diagnosis of idiopathic pericarditis. We should also consider the significance of that atypical mesothelial proliferation mentioned in the biopsy. Is 8 millimeters of pericardial thickening typical for a simple idiopathic case, or is it a major red flag? Finally, we must weigh the risks of applying the idiopathic label too early in a patient's course. These questions serve as a warning against the comfort of a quick answer. Let us evaluate how our different perspectives react to the label of idiopathic disease. The reasoning at stage 3 highlights the trap of premature closure. The resident expresses significant concern, noting that an idiopathic label is highly atypical for a patient with a 4-week constitutional prodrome. As you can see in the middle box, the attending slams the premature closure, arguing that organizing fibrinous histology does not exclude poxybacillary tuberculosis. They warn that the patient is heading toward impending constriction. The expert agrees, defining the biopsy as non-diagnostic rather than reassuring. They emphasize that a favorable response to non-steroidal anti-inflammatory drugs is not a diagnostic test for idiopathic disease. While the attending warns of impending constriction, the patient's clinical course takes a turn for the worse. In stage 4, we see the manifestation of a rigid heart. The patient was readmitted twice with worsening dyspnea, edema, and fatigue. On examination, as noted in the clinical failure box, His jugular venous pressure rose to 10 centimeters, and both Kussmaul's sign and a pericardial knock were present. Looking at the definitive hemodynamics on the right, the echocardiogram now shows 17 millimeters of thickening, a septal bounce, and annulus reversus. Cardiac catheterization confirmed the equalization of diastolic pressures and the classic square root sign with a pulmonary capillary wedge pressure of 27 millimeters of mercury. These dramatic hemodynamic changes force us to reevaluate the mechanical failure occurring in the heart. Our final audience pause addresses the mechanics of this failure. We need to understand how annulus reversus on an echocardiogram localizes the problem to the pericardium. It is also vital to ask why the pericardial thickening doubled from 8 millimeters to 17 millimeters in such a short time. At this stage, we must decide if there is any remaining role for medical therapy or if the situation has become purely surgical. So, finally, consider what the square root sign represents in this specific physiological context. These signs all point toward a heart that can no longer expand to receive blood. With the evidence of mechanical failure mounting, we return to the reasoning team for their updated assessments. At stage 4, the reasoning team identifies an established restrictive shell. The resident notes that the trajectory now confirms overt constriction and urges a radical pericardiectomy and empiric anti-tuberculosis therapy. The attending critiques the previous delay and demands an intraoperative frozen section and a broad polymerase chain reaction panel on the explanted tissue. As you can see in the expert box, the pivot is now the objective proof of constrictive physiology. The expert reframes the entire clinical question. We are no longer asking what is wrong, but specifically what caused this constriction. In this context, it is tuberculosis until proven otherwise. As the expert frames this as tuberculosis until disproven, we look to the final surgical pathology for the answer. Stage 5 brings us to the finality of the case where the explant reveals everything. A radical pericardiectomy was performed, and the pathology results shown on the left describe extensive necrotizing granulomatous inflammation with multinucleated giant cells. Although the initial stains for acid-fast bacilli were negative, the microbiology growth on the right tells the full story. Follow-up cultures of the surgical tissue eventually grew Mycobacterium tuberculosis. Interestingly, a previously obtained sputum culture also grew the bacteria, which was not known at the time of the initial workup. The final diagnosis is tuberculous constrictive pericarditis. Now that we have a final diagnosis, let us trace back the entire journey of this diagnostic evolution. This diagnostic evolution chart summarizes how our reasoning shifted over time. We began with a suspicion of tuberculosis or malignancy based on the patient's origin and constitutional symptoms. As you can see in the second box, we then fell into the idiopathic trap by anchoring on a negative percutaneous biopsy and temporary symptomatic relief. The third stage shows the transition to mechanical failure, where 17 millimeters of thickening and clinical signs prove the existence of a restrictive shell. Finally, the tissue culture and the presence of necrotizing granulomas provided the definitive microbial cause. Understanding this evolution allows us to extract critical teaching pearls regarding diagnostic pitfalls. Our first set of teaching pearls focuses on diagnostic pitfalls. As you can see in the non-steroidal anti-inflammatory drug response box, a favorable reaction to these medications is not a diagnostic test for idiopathic disease. In fact, it can mask specific inflammatory causes like tuberculosis, leading to a false sense of security. On the right, notice the pearl regarding biopsy sensitivity. Percutaneous biopsy has a very low sensitivity, often between 30 and 50% for paucibacillary tuberculosis. Therefore, a non-diagnostic biopsy in a high-risk patient is never reassuring and should not lead to the closure of the diagnostic process. Beyond the pitfalls of labeling, we must also master the physiological clues that signal advanced disease. The second set of pearls highlights the physiological clues of the constrictive state. Looking at the echocardiogram hallmarks, the presence of a septal bounce and mitral annulus reversus are pathognomonic for constriction. These findings indicate that the heart is struggling against an external rigid barrier. On the clinical side, as seen in the right-hand box, Kussmaul's sign and the pericardial knock are loud signals of a rigid heart. These are not just interesting physical exam findings. They are urgent indicators that should prompt an immediate surgical review. Recognizing these signals leads us to the core take-home messages for any practicing clinician. The take-home messages on this slide serve as a summary of the lessons learned. First, in any patient from an endemic region with constitutional symptoms and pericardial thickening, tuberculosis is always the diagnosis to beat. Second, we must never anchor on an idiopathic label without truly excluding specific causes. Third, remember that anatomic progression, such as thickening over 4 millimeters and loculated effusions, are major red flags. Fourth, surgical sampling through a pericardiectomy provides a much higher diagnostic yield than percutaneous methods. Finally, always monitor for infectious potential, as even extrapulmonary tuberculosis can coincide with positive sputum cultures. To conclude our session, let us look at the final synthesis of this challenging case. In final synthesis, this case reminds us of the journey from a sharp pain to a rigid shell. A 50-year-old man was initially mislabeled with idiopathic pericarditis following a non-diagnostic biopsy. However, his persistent constitutional symptoms and rapid anatomic progression to 17 millimeters of thickening eventually revealed the true nature of his condition. This serves as a critical reminder of the paucibacillary nature of tuberculous pericarditis and the dangers of premature diagnostic closure. Bedside tests were insufficient, and only definitive surgery and tissue culture provided the truth. Always maintain a high index of suspicion in high risk populations. Ask, screen, counsel, provide.